Hi, I'm Kyle Hansen. I'm the new CANS Program Manager for the Division of Behavioral Health. We recently created a Center of Excellence to support several focus areas, including the CANS. The goal of the Center of Excellence is to support you with training and content that will help you implement best practices. In this video, Dr. Lyons is going to show how a CANS can be easily completed once you've gathered the information for a comprehensive diagnostic. If you know the family, completing the CANS should be done easily and quickly without asking every question. It's a process of organizing what you know. So without further ado, I'm going to introduce Michelle Schildauer and Dr. Lyons to show us how this can be done.
Thanks, Kyle. Hi, I'm Michelle. I'm going to be presenting a case with a youth and a family in order for Dr. Lyons to complete the CANS based on the information I'll be sharing. Are you ready, Dr. Lyons?
Just tell me about the youth and family.
Rachel is a 10-year-old Caucasian female who lives with her biological mom, dad, and younger brother who's 8 years old. Rachel is having negative thoughts about herself, which include not feeling good enough and sporadic episodes of crying. Mom has concerns about Rachel being on the autism spectrum, but she's not received any psychological testing. She is currently receiving medication management for anxiety and major depression. Rachel has a history of self-harming behaviors, which include slapping herself, biting herself, and hitting herself. Mom reports these happening whenever Rachel is having strong emotions that she's unable to cope with. Rachel has a very open and supporting family. Rachel is smart, outspoken, funny, and she's an excellent reader. Symptoms of anxiety and depression began approximately 1 year ago. She reports very negative feelings about herself and does not believe most things will end in a positive experience. She gets frustrated easily and will act aggressively toward herself by hitting and biting herself. Her moods change rapidly, going from happy 1 minute to crying the next. Mom has attempted to engage her in several physical activities, but when Rachel begins the activity, if things don't go perfectly, Rachel will quit and she cannot be engaged to rejoin. Rachel did report feeling different than other girls and wishing she was a boy. When asked why she reported this, she stated that she does not want to have a baby and that boys can take their shirts off whenever they want. Rachel does not have any female friends, all male friends. These symptoms don't meet the diagnostic criteria for a gender disorder, but it should be something to discuss with Rachel further. This clinician encouraged Mom to obtain a neuropsychological evaluation to rule out autism. Rachel is currently receiving medication management for the past year. She has no history of physical or sexual abuse. She's not involved in the legal system, but Rachel was born with a heart defect and required heart surgery at the age of 3 months. Rachel sees her cardiologist every 2 years. Rachel is closer to her father than her mother, but she gets along very well with both of her parents. She argues with her younger brother, but it's all within normal limits. No physical fighting. Mom reports being much more social than her husband and will often take the kids to social functions and leave dad home. The family identifies as liberal Latter-day Saints, or LDS. The family is active in their church. Rachel enjoys collecting Pokemon cards, playing video games, and swimming. She is currently on the swim team. Mom identifies her current supports as her Latter-day Saint ward, her parents, and the younger brother. Rachel is currently in the 5th grade in a traditional academic setting, and she is able to complete all of her activities of daily living that are appropriate for her age. So what other questions do you have?
So it sounds to me like let's just go through it. So in terms of the sexual, for the traumatic childhood experiences, there are mostly zeros with a 1 on medical trauma. It's probably
Right.
a 1-2 debate. I might give it a 2, but what did you think? Is it?
It doesn't appear to be impacting her daily life now. She's been, she goes to the doctor every 2 years, and it's been stable. So it doesn't seem like there's any traumatic reactions or anything like that are popping up.
So one fits.
I think so.
Okay, and the education of the school is great. The school's a good partner, and she's doing well at school.
She is. Mm-hmm.
Okay, so I think she got notable strengths. I mean, I'd be very tempted to give her centerpiece strengths on family, on educational setting, on spiritual religious, on community life, on relationship permanence, on involvement with care, use of free time. I think all of those are like really quite good. Focus. I mean, probably a 1 on peer influences. Legal permanency, of course, is a 0. Cultural identity is probably also a 0. So does that make sense to you?
It does. I agree.
Let's see. Coping and savoring, however, it doesn't sound like she has a great set of coping skills.
I agree.
I might give that a 2. That might be, and it was a little unclear to me about optimism. What's her sense of herself in her future?
She has a difficult time moving past difficult times, meaning it's a little bit all or nothing.
Yeah. So maybe it's something that you really need to develop her sense of herself in the future. So she's got some stuff to work with, maybe. So I would probably give her a 2, if that makes sense.
Yeah.
All right. And resilience, she's aware of her strengths. Can she use them? Or is she aware of her strengths? I mean, where does she sit on that?
I think she's aware of her strengths and has, good self-confidence. However, I don't know that she's made the connection that she can use her strengths as a coping skill.
So that would be a 2.
Mm-hmm.
All right. So let's see, for functioning, she's doing quite well. So, I didn't ask about sleep. Is she doing okay about sleep? What's her sleep like?
Mm-hmm.
Okay.
She's doing well.
And her school is fine?
Yes.
All right. So she's actually pretty good. I have 1s on social functioning, on developmental for the flag to get that assessed, and on medical. On sexual development, she's young, so it's a little early yet to be acting on that, but to keep an eye on it. I did put that as a 2 on identity because it sounded like it might be something that you want to chat with her about and kind of
exactly
help her kind of figure that out. In terms of her behavioral health needs, not adjustment to trauma. Her emotional regulation, I'd probably put as a 2. Not psychosis. Attention concentration, sounds like it was fine. He didn't really mention anything about paying attention, although she has a lot of volatility with her moods and so forth. Right?
Exactly.
So not really impulsive behavior so much as volatile mood states. Yeah. Okay. So depression a 2, conduct and substances 0, attachment doesn't sound like there's anything there, eating disturbance, not anything there. Behavioral regression, somatization, not anything there. All right. So anxiety a 2, anger control probably a 2, and the mood disturbance probably a 2 as well, right? But not traumatic grief or triangulation or opposition, right?
Right.
All right. Sort of like with ICANS, there's a little problem with the technology here, but it's so the only risk behavior I heard you talk about was non-suicidal self-injury. True.
That's right.
Everything else would be a 0. Yeah.
Mm-hmm.
All right. And then we don't need to do the transition to adulthood yet. Now, for the caregivers, sounds like for the most part, these parents are really strong and have a lot of good assets, resources, but sounds like they need some help supervising, working with Rachel, and they might need some knowledge about how to do that. So
Absolutely.
those two things as 2s, but everything else would be a 0. Is that fair?
I agree.
Okay. All right. So really the goal here with Rachel's situation is to work with the parents to help Rachel, and to work with Rachel directly to help her learn how to better control her moods, and to not be so down on herself. And you might even use her considerable strengths as a strategy to assist with that. All right. So there you go. How do we do in time?
Wow. 15 minutes. It is possible to complete the CANs in 15 minutes based on the information from the Common Diagnostic Assessment.
Yes, that's exactly right. And so the idea is to just pull together the information you already know. Now, notice I did check back with you, right? That's the consensus piece, because you're checking back with the family. Did I get this right? Do I understand this? So what do you think, Kyle?
I think that's pretty impressive. I'm wondering how you get more information on how you don't necessarily ask about everything, but some things you did follow up on.
Well, she said about the non-suicidal self-injury, and so I kind of, when she's describing the depression, anxiety, and the self-injury stuff, that's a constellation, so it's less likely there's other risk behaviors. So I just ask about all the risk behaviors as kind of a lump. Is there doing anything else? And so you can kind of be efficient about that. You're not saying, did you set any fires? I mean, that's not really, people would tell you a fire, right? And so I think that's kind of how you think this stuff. You don't have to ask questions that are obvious, that you can count on it. It's just like with quality assurance, if it's not documented, it doesn't exist. If you're talking to families about what kind of help they need, if they're not bringing it up, then it's fine, it doesn't exist. And so you can ask these kind of global questions. So when she said the only traumatic experience was the surgery, then you don't really have to ask about all the other. I didn't have to ask if she was involved in a war or something like that. It's just not to the point. It's a waste of time. So anyway, that's kind of the guide I use, is you kind of think about the story and what makes sense of that story, and then ask kind of global questions. Now, you notice I did ask specifically about sleep, because there was nothing in Michelle's description of Rachel and her family that talked about that, and she did have depression, and so depression and anxiety are sometimes associated with sleep. So I wanted to ask specifically about that, because that would make sense clinically.
That makes sense to me. I appreciate you giving us an example of how to organize it in a way that, doesn't take that long if you know what you're doing and you know the language.
And it's abusive to families to force them to go over the same thing more than once. And there's absolutely zero intention with the CANs to make that happen. You already have the information. It's just a structure of how you record that information, carry the story forward, and allow us to see whether the story changes over time. So that's a really important thing for people to fully understand, that the CANs is not a process of asking questions. It's a process of organizing information that you, in all likelihood, already have.
Well, thanks, Michelle and Dr. Lyons, for illustrating that for us. Really appreciate it. And if you have more questions or suggestions, please follow up with us at iti@dhw.idaho.gov.
All right. Thank you both for what you do for others. Appreciate your good work.